7 o'clock, so we will get started. And we are going into executive session to start. So you guys get to go hide in the hall for a while. Okay, any public comment?
I just wanted to ask John, has there been a service or is there?
There was.
For what?
I have the students this last year, it was on Monday.
It was the 13th. It was the 13th. I thought I.
Yeah.
Thank you.
Yeah.
So next we need to approve the June 27th minutes. I thought they were good. Didn't see any changes needed. Anybody else? All in favor? Aye. Anyone opposed? John, you're up.
Hey. So we took the opportunity the first week of August to celebrate National Health Center Week and also celebrate the efforts of all of our staff and recognize our 50 years of public health service to this community. And you can see the Billings Gazette from July 1974 right there. And 40 years of community health service as Montana's first community health center. And so we're going to spend the rest of the year celebrating those milestones and sharing some historical accomplishments. We had proclamations from our county commissioners, thanks Don, Mayor Cole, as well as Governor Gianforte, honoring the commitment and impact of community health centers across the state and right here in our own backyard. Thanks Crowley Fleck for ice cream throughout the week. Thank you, Stuart. And Altana also brought their treat wagon music on one of the days to help us celebrate. We had a community fair, patient fair during Patient Appreciation Day. We had the Met here as well as Cover Montana, helping folks get re-enrolled in Medicaid and healthcare coverage. And we also had our healthcare for homeless breakfast Thursday at South Park. Treated about 100 folks to breakfast there. We now have access to the secure Microsoft Teams page, which when our tech issues get sorted out, we'll be able to share that with you and show you how to access now board materials, the recordings and all communications. Had a good call last week with all of the large health departments around the state, talking to Gallatin, Flathead, Helena and others about how they are sharing their recordings publicly now that it's required. Many of our other municipalities have been doing this since COVID, since they went to video meetings. And so we'll be the new guys.
Does everybody have their mics off on their?
All right.
We're there together.
All right. That seems good. All right. So now that we are appropriately recorded and talking about meeting recordings, we'll continue to keep them in a secure place as well as post them publicly. So this is just a friendly neighborhood reminder that this meeting is now live and recorded. And on the web for the public to review. And it'll remain that way for the long-term future. Let's see, last week we had a meeting with DPHHS leadership, Director Brereton, the interim state Medicaid director, as well as the Human Services director, to chat about ways you can work better together find synergies that'll help improve the lives of Montanans. We also continue to conduct outreach to our Medicaid patients who've lost coverage monthly. And as you can see there, we are not losing any more Medicaid members, which is a good thing. However, we are not gaining them back as quickly as we would like. And so we have a number of pending applications out with the state. That number continues to climb every month. And they have 45 days in which to get back to the patient and put them back on the rolls. But we are seeing delays with that process.
And then what happens when the 45 days are exceeded?
They could take 6 days or 75 days. It all depends on how the backlog is, how big the backlog is. There's no real automatic or presumptive enrollment. Our folks are following up, patients are following up. But they are still short-staffed and struggling.
I'm assuming that if they are being, it's effective that day, it doesn't go back to their application date.
It is retroactive.
It does.
Yeah.
So that's a plus.
Yeah. So we've seen a few of those, Shanna, retro, but not anything.
Really limited.
So we'll continue to work on that. We'll continue to get folks back re-enrolled and get appropriate folks re-enrolled into the Medicaid roles. Last month, we also had a Ryan White site visit, Ryan White HIV/AIDS program. HRSA came to visit, provided us with some preliminary minor findings. We now have less than 45 days to complete a report on any of those findings that we need to continue working on. And so we'll receive that in the next week or so. We have an updated space sharing agreement now with SD2, and we will be starting to provide services in senior high beginning of this school year. So we'll get into senior high school here downtown, provide behavioral health and medical services to teens who are there, and hopefully look to expand our school-based services across SD2 with the ultimate goal, 3 to 5 year plan to have a school-based health center in every SD2 school.
And the presentation yesterday at the foundation meeting, I thought was excellent. Could we have it here at some point?
Sure. Got that?
Yep.
All right. All right. So we'll continue there. We did have the opportunity to welcome our new medical students to Billings. We had the MCOM, RVU, Rocky Vista Medical School white coat ceremony recently. And they welcomed their class of 2028 in the door. So time flies. Let's see, we are restarting now that Lee Boyles, the new CEO of Intermountain Health, has been here for a while. The alliance back up and our efforts, our joint efforts among RiverStone, Billings Clinic, and Intermountain. And we're going to continue to meet quarterly beginning in September 24. And our first issue is going to be on addressing the health and well-being, behavioral health and crisis needs here locally. So we're trying to pick one thing that unites us all as healthcare providers and health systems and chip away at that issue. Also had the opportunity last month to talk to Congress again, joined the Connecting to Coverage Coalition, virtual staff briefing on Capitol Hill, and talked about Medicaid re-enrollment and future re-enrollment periods. We went through hell with this post-public health emergency re-enrollment cycle. How do we prevent that from happening again? And this is going to continue to be an annual process. How do we make sure that we fix that? And then last week, I had the opportunity to go up to Bozeman for a CMS Innovation Center hackathon on rural and frontier health. Joined folks from across the state and region, folks there from California, Stanford, all over the country came out to join us, and we talked about improving federal regulations and federal programs to pilot potentially here in Montana and other rural frontier locations to improve access to healthcare. And then this week, Region 8 HHS Director Lily Griego visited Billings on her tour through Montana. And we talked about improving access to behavioral health. We talked about Medicaid, the snafus and the need for continuing expansion, as well as other opportunities for HHS and HRSA to help us with teaching GME, as well as some of our physician pipeline issues that we have. Getting into public health now, our infectious disease team and the YMAG group, the also medical alignment group, we've expanded that now to include some of our LTACs and SNFs. So we're reaching out into our nursing home population as well as our long-term care facilities with some infectious disease education and communication. And they also reached out to SD2, and we have a letter going out, joint letter from all three medical directors, of the hospital adults to parents of SD2 students, encouraging them to get vaccinated this season. So we want to prevent any local measles or varicella outbreaks from happening, as they are in different places around the country. And we also have, before I get into the overdose report, a minor cryptosporidium outbreak popping off around the region. That is a parasitic bug, causes GI symptoms, and is chlorine resistant. So it's in pools, out in the river, lakes around the region, and there's a strong tie between crypto and our cattle population. So one of my hypotheses is in my head is all this rain that we're having, flushing all of that other stuff from the fields into some of our bodies of water, and causing an uptick in cryptosporidium. We have 22 plus that we've confirmed. We're investigating another handful. Some of those, our largest group came from one local aquatic park. Another came from a family trip out to Minnesota. And so we're continuing to investigate. We've put out a notice to all public pools for hyperchlorination to help kill the bug and stop the spread.
Is it easily resolved?
No, highly resistant.
So later this week, you mentioned to the clinic board that we should avoid swimming in Lake Elmo. Right?
Yes. I would avoid the lake. We had a really good conversation with FWP about the lake, about the river, and just urging caution and allowing, making the general public aware to take the necessary precautions.
If it's chlorine resistance, does hypochlorine do anything? Is there anything else that you can?
Hyperchlorination does help. It's a multi-walled parasitic organism. It's encapsulated. Yeah.
Michael?
What is drinking water like? Public water is tested for regularly.
Yes.
Daily. Do we have any public water? Probably not.
Right now, we don't have any water issues. Just good.
Our public water treatment facilities do a fabulous job of taking care of these kinds of bugs.
Yes.
And it's filtered out. It's not chlorinated out. It's filtered out with their filtering systems. But we've never had a problem with drinking water in Billings.
So that covers Billings, but are we concerned about any of the outlying communities?
It's an ongoing investigation right now. So our EPI team and our environmental health staff are out there taking a look at the wide depth and breadth of any potential issues. We're going to send out a HAN, to all of the providers here in the community so that they're aware and monitoring for it, right? It could, say, oh, you just have a GI bug, or maybe it's a coli. We want to be able to test for it and identify, is it something else?
I just curious, when you talk about pools, so you got 60 hotels and buildings. So is it something that can test for within the pool, or how? I mean,
Yes, that's a good question. You can test the pool water.
you can.
Yeah. It takes several days to get the results back, but
Okay.
most of the public pools are closing now before we can get some results back anyway, so.
Okay. Yeah.
Not the indoor, I mean, the outdoor public pool.
Right.
You know what I mean? We're getting to the time of year where they're starting to shut them down, so.
Right. But you've got 60 hotels in the city of Billings, 6,000 rooms. And most of them have pools of one sort, either indoor or outdoor, that are still being used and are used year round.
Yeah.
The indoor pools are used year round, which the majority of them are, so.
So far, the outbreak's been small enough and we've been getting the case notifications quick enough that our communicable disease folks have a really good idea of where people contracted it from.
Yeah. Is it contracted because of swallowing water? Is that,
Yeah.
that's how you get it?
Yeah.
Drinking.
Yeah, so right now we have 20,
Drink more alcohol, I guess.
23 confirmed, 23 confirmed with a common point. And so we identified a common place. It's, it's really, you don't swim with diarrhea. We've got kids who are out there and they bring it to a specific location, a specific, the hypofluorination guidance that we've shared with all owners of public swimming facilities is really a precaution. We want to stop it. And there are so 23 confirmed, 26 probable. And just to give you an idea, I think we had a total of 9 cases last year and 4 the year before. So it's popped up.
When the pools close over the winter and things get cleaned out, does it reset for next year, or does it hang out and
It'll go away.
it'll go away?
It needs it like
Just
any
needs
good
some
like any good parasite. It needs a host. All right. So it's just another update for your information. I provided our year-to-date overdose report as of July 31st. This report, there have been 110 documented overdoses here in Yellowstone County that we were able to have added to the OD map. 3 of those were fatal, 107 were non-fatal, and naloxone was used in, Narcan was used in 50 of those. 30 were of unknown use. And so just on average, right now, the county is averaging about 15 overdoses a month. Opioids are responsible for the highest number of those, being 23 of those so far in 2024. And the chart that you see on page 8 is inclusive of other suspected drugs. So opioids were the primary cause, and they could have had multiple opioids on there. So it could have been fentanyl and oxycodone, etc. So ODMAP captured about a 15% decrease in total overdoses and a really significant increase in the number of fatal overdoses. Good news. So we are getting that tells us one potential thing there is that there's no bad batch of drugs in the community right now. When we see fatal OD spike, it's usually tied to a more lethal dose of drugs that could be coming in and across the state, or that is also means that we're using Narcan more and getting to people more readily.
Typically, with the Narcan's
used? Is it like an emergency room or
By first responders, by law enforcement, and by individuals who are using themselves. We have a current naloxone saturation level of about 380 kits per 100,000 people. We've distributed. It's nasal or intermuscular. So we have two types out here in the community that we distribute, and it's the nasal spray or injectable. The largest hotspot continues to be downtown, as it has been for several years. But one notable change in 2024 is that we're seeing specifically west of 24th, some mapping end up closer out to the west end. We'll continue to monitor overdoses and drug use and try to prevent, at least prevent deaths as much as we can. The interesting flow, and Eric, correct me if I'm wrong, what the agents tell us is that if you have a bad batch of drugs, it shows up on the west side of the state first. It's coming from points west, Seattle, Portland, Idaho, coming kind of through the Flathead and following the highway through Missoula, Butte, and Helena, and then Billings and beyond. So law enforcement now is getting a heads up when bad batches start to enter the state, at least for us in Billings, and try to stay on top of that. Any other questions?
What about COVID, Stan? It's
a good question.
Yeah, COVID.
If we were monitoring as a state and an agency, we'd share some additional data, but it's a problem. It's still out there, but we are not tracking as we used to. We're relying on the national CDC data and metrics to go. Michael.
New strains emerging,
Yes.
get vaccinated.
Yes.
And new vaccine coming.
And new
The
vaccine.
vaccine is coming, will be
Yes.
available soon. Don't rely just on the old ones. Probably have good protection if you got one last year, but get a new one this year.
Yes. And there's a combo. There's a combo this year. There's combo flu COVID
In one
vaccine
shot?
in one shot coming.
I haven't,
Yeah, I didn't have much trouble with both arms.
middle of September to early October is the best time to do it, to get protection throughout the winter when it will probably come and get us.
Report on NPR as I was coming in this morning. The new vaccine will be out within days. New COVID vaccine will be out within days. So there'll be some distribution timing to get it out in pharmacies.
Yeah, and we will have it and we will make it available to all of you board members who want it at a future board meeting.
And how long a period between your last shot and this, the next one? There's a recommended waiting period. Is it like 3 months or something?
Months.
3 to 6, yeah.
I don't give medical advice. I'm sorry. I'm not licensed for that. I don't want to go to jail. I just speak as an immunologist. I don't recommend, I just,
Isn't there some overlap?
I still don't want to go to jail.
My attorney will be calling you.
Wishing it's fast. So COVID is still out there. It's still a concern. It's still something to be mindful of. So your best protection is to get vaccinated. All right.
Anything else? Next item is our chief medical officer report. And Megan sent us a nice report that you can read. Went through the stuff about providers, how well we're doing with our residents, and how they are helping Montana's healthcare force. Anything else, John?
Just gonna real quick. There was an update about our school-based health centers and expanding to senior high, and Katie Keith will be our main medical provider there at senior high.
Nurse practitioner.
She's our, NP, and if you've met Katie, you know how well she's just gonna mold into that high school population and build relationships with the kids there. So that's been ongoing. And I did want to I gave everybody an email update, but one thing that I did not cover and Megan did was the sublease issue in Joliet, Montana, at our Joliet clinic. And so we were notified earlier in the year that Fairtooth Buildings Clinic needed to give us 6 months notice that they were going to end our sublet on that facility there at the Joliet Community Center. And so that will be coming to a close. We currently, in the current state, have negotiated a 1 day a week extended day towards the end of the year when that need to, they need to expand therapy services. So they're expanding PT, speech, OT in that space and in that building. And, we want to be a good partner with them and help them provide increased access to therapies. And so we're working out a mutually agreeable termination arrangement where we'll move out of that space and into different space eventually. So we're examining options. There's a potential plot of land that is town owned there in Joliet that we're working out on the Broadway space that we might be able to build on. There's also a building available for lease in the town of Joliet and going down tomorrow to take a look at and see if we can make that work. So a lot of work being done in Joliet and a community notice campaign to say, hey, we need a piece of property or we need a physical space to be able to move our clinical services there in Joliet. So stay tuned on that, but I wanted to make sure the board was aware.
Okay, anything else? Jim, you're up.
There's a bunch of information in front of you. I have no comments about the May statements. If you have questions, ask them at your leisure. This report. We talk about June, that's the fiscal year end, and that's where the committee focused its time. First package that I'm going to look at is just the RiverStone Health June 2024 financial statements. Because of our habit this year, I'm focusing on cash flows. The total 3 pages into that. It's June 2024 financial report, balance sheets. On the front page, RiverStone Health logo in the upper left-hand corner. Got the combined one that's belong. On the cash flow. Month. Third of the way down that page says net cash flow provided by used in operating activities, billions fixed to the goods, to the good. That was from operations in the month of June. We created $1.6 million in cash. RiverStone Health sourced $1.6 million out of its routine operations. The big item halfway up to the top of the page is tax receipts. So the county tax receipts paid to us semi-annually, half of it between May and June. I go back down to the net cash provided line and look at the year-to-date. $1.1 million went out during the year. Not what we want to see, but under the circumstances, that's okay. We survived it. Reconciles down to the cash balances at the bottom. It always blows me away as a former hospital CFO when we get to this point. Look at 40% the way down the page, net cash flow used in capital operations. The capital spent to support this. Darrell, I'm sure you would remember numbers a hell of a lot bigger than $500,000
Yeah.
for a $60 million operation. That's just, my background is such that I've seen much bigger numbers in general healthcare sites. I'm going to move forward one page. The June 2024 financial report, statement of revenues and expenses. This is the activity in the month. And then the year to date would be the activity in the year, from the day that starts the period to the day that ends the period. 30 days of activity in June, 365 in the year. I looked down the page. My background was such that I focused a lot on net operating income. I looked down the page and saw on the year-to-date numbers, the actual $1,024,000 in the bucket with brackets on it, a loss, operating activities, and 809,000 under budget. I looked up at John and Shannon and I said, that's a damn good job. Under the circumstances of last year, that is a damn good job. You don't like to see the brackets around those numbers, but given what the organization went through. That's good. All right, we get below that, we go into non-operating activities, stuff that are things that aren't routine to our business purpose. And just like I grew up in California, as I think you know, pigeons come back to San Juan Capistrano someday, same time every year. The monarch butterflies come back to the eucalyptus trees that are somewhere south of Pismo Beach. And every goddamn June, the state makes adjustments to that pension fund. And it came back to bite us in the backside on the non-operating activity. In the June numbers, in the actual, the bottom third of the page, under non-operating revenue, PERS GASB 68 adjustment, $618,000 of additional revenue. Thank you, state. The lower non-operating expenditures, PERS GASB got on an adjustment of $1.9 million expenses. I don't have the energy to get into pension accounting this morning. This is becoming, I don't know how, what was it you said, Shannon? That something's got to change. I mean, somebody's got to be getting suspicious about the
underfunded plan.
Yeah, the internal control, the accuracy of their work. I don't know.
Yeah. I think last year was about 1.7 million. I mean, it's significant every year for our organization.
Yeah. And you expect when interest rates are moving for there to be adjustments in the pension liability calculations, drive these adjustments. But we've gone through interest rates going up, they are now stable. It should be long-term expectations, you think, would be for lower interest rates. So I'm waiting for these to be net credits to come back and be to improve our bottom line. Don't know. Any questions about the income statement? Right now, I'm going to go forward one more page to the balance sheet. There at the top of the page, your June 30, cash is almost $8 million. Okay. It's down $1.5 million from the end of last year. Don't forget that 3/4 of the way down the page under liabilities, further inflows, there is unearned revenues of almost $2 million. Embedded in that number is about $1.7 million of money related to COVID mitigation management activities. And I won't be able to explain this correctly. What did the government tell us in the last month if they want this back sometime soon?
Yep, we have to spend it out by June of 25.
That's an ominous request. That's a difficult request to meet. I'm not sure what steps we will take. We've had some conversation in committee.
How closely related to COVID does the expenditures have to be?
Staff.
That's what we're working on.
Yeah, it's open to interpretation, but I want to make sure that we have clear documentation that it's approved, right, before we do anything with it and then get in a situation where we have to pay it back. Pretty much anything but actually purchasing vaccine. It's weird. Yeah. Yeah, it has some sort of tie to COVID. You can get away with it, it sounds like, but we'll make sure we have clear documentation.
Purchase the vaccine and then sell it.
We have, we have some,
In front of everything.
let's go. We have some good plans, but we've got a group working on some engineering solutions, some, COVID the vaccine needs to be stored in cold storage. And so we have the opportunity to improve our cold storage systems. We have the opportunity to improve the resiliency of those systems as we have more power outages and severe storms around the region. We can buy some generators and install those potentially, some battery backup for that. We have the opportunity to market that we do have vaccine available, and we are still willing to vaccinate members of the public. So we can do some public information campaigning and sharing. So we also have the ability with these funds to potentially use them to lease a mobile unit. And so could use a sizable chunk there to help us meet our mobile outreach goals and mobile care out in the rural frontier communities. So a lot of different opportunities, none of which add up to a total of the sum of money that we do have available, but we're going to do our darndest to get to that number.
All right, one other thing I'll call your attention to is on Darlene's balance sheet, which is YHP. Pull that up. The top portion, the last line of the current assets. First block is current assets, just above the total line is Yellowstone Bank savings, almost $1.6 million. That is the cash we got for the sale of the hospice home. It was, as I understand, it was completed on June 30th. And it is significant in the context, if you look back at that cash balance on if we looked at the cash balance on the combined statement, we have bonds outstanding. There is an indenture describing those bonds, how they'll be used, restrictions on how we can use that money, and targets, financial targets that we have to hit at the end of the year on June 30. The target, as I recall, Shannon, is days cash on hand. So you look at the average consumption of cash on a daily basis for the organization, divide that into the cash balance or the number of days that result, that quotient high enough to match or exceed what is in the bond indenture. It is unrestricted cash, as I recall. So the COVID money is not included. It's excluded from that calculation. And this money came in on the 30th of June. Will be in our audit. Our audit is completed and delivered to the rating agencies. The MBI, probably the insurance company, covers the debt. And we will be compliant this year for staff's calculation. So that's a big deal. Any questions about any of the comments that have been made, any of the statements? Thoughts from your reviews? Hearing none, Shanna's notes are really good. They're really helpful to me. Short, concise, bullet points. If you want to practice your understanding of these statements, go to those bullet points. Pick a couple of them each month. See if you can find on the statements what they're referring to. Find, take any one of them, take 2 or 3 of them, until you fall asleep. It's a great cure. Take this to bed with you.
Does it help you go to sleep faster?
The CPA could probably give you stress.
But for the rest of us.
Yeah, if you don't understand it, it will help you go to sleep. But you can learn your way, maybe it will help you learn your way through the statements. That's it, Coach. That's all I got.
Any other questions for Jim? Okay, we need a motion to accept the August 21st notes. Second, all in favor?
Aye.
Any objections? Next, we need a motion to accept the June financial statements.
Don't move. Second, Warlick.
All in favor?
Aye.
Anyone opposed? And third, motion to accept the May financial statement.
I'm worn out. Yes. Warlick. Second, Warlick.
And okay, all in favor? Any objection?
Just make it easy.
Okay, Lionel, you're up.
Damn, never mind.
Well, that's what the agenda said.
So we, meeting discussed, an issue that has to do with, employee safety when they go out and do whatever it is that they do. One of the things that I was surprised to find out is that we have 122 employees that are actually out in the field doing things. And we haven't had any kind of standardized orientation and procedures to ensure people's safety. And so they spent the hour talking about how, and having a presentation of how the organization has combined various programs in hospice and home health and all these sorts of in the clinic as well, into how we can have at least a standardized baseline safety process policy, and then how it can be used across the board to various specific areas. So that's what it's about. And there's been a lot of progress. We had a presentation, and somehow why did that cross? So it was sort of a partial presentation, but it's still quite interesting. And John, anything else?
Well, I asked him to give us a specific example of something they dealt with, and they never came up with anything.
I got one.
Oh, good.
They talk
Please
about
tell
dog
us.
bites.
So,
All right.
Dog
So-
bites is a specific example.
so there's all sorts of safety issues that can arise, but I think one that I've had dealt with in the past was you have staff on the road, and what if something happens to them between point A and point B? And so we had one of our staff members who was out there on the road somewhere between Columbus and Nye without cell coverage. And they were able to call in on their device because they had a flat tire. And the only reason that they were able to notify us and we were able to go out and assist them was because they had that device on them. So
And everyone got those devices when?
It's not everyone, it's just,
it's our home care, it's our home health and hospice staff. And they got those about 3 months ago.
Yeah, that's about right.
there's a bunch of people that go out like this, like the food inspection guys and stuff like that.
Yeah.
There's other departments that.
Yeah, we started with home health and hospice. One, they were the team that felt they wanted them, needed them the most. And I'd agree with that because they're the ones that are most on the outskirts of town. You know, the majority of our environmental health staff and folks are out in the city or in towns across the region, and don't spend as much time as the home health and home hospice staff in a person's home and away from potential coverage.
These like antenna device.
Yeah,
It's basically.
yeah. There's a pendant and then there's a larger kind of box that it's basically a GPS beacon, and it can call directly to emergency services, or it can call back home to home base and alert definition.
And that can be monitored here, in fact, somebody is monitoring.
Yes.
Here. But not everybody carries. That we don't have enough of them. So the answer is always money.
Yeah, so we paid for the initial batch through a Bear Family Foundation grant and foundation money, and got those out to the first couple of folks. And now it's a matter of, hey, we've got proof of concept, let's distribute them.
How many are you short in one folks?
That's a good question. Eric, do you know?
Sorry.
How many are we short?
Oh, I don't know the exact number, but I mean, the only people that have them right now are home health and hospice staff. So I wouldn't even estimate a number of that. And you know, so not all field work is the same, right? Primarily is a business to business transaction. So generally speaking, that's a little lower risk than going into somebody's house and, you know, being in an uncontrolled environment. In some of our nurse home visiting programs in public health, they have a little more flexibility of they can meet with people if there are safety concerns. So they don't always have to be in a person's home. They can meet them in a library or in a coffee shop. So they have a little more ability to control the safety factors around them. And then, you know, we have other folks who are primarily out in the community doing presentations in controlled locations like libraries or, you know, tabling at events where there's structure around it. So really the home health and hospice folks that got it first are the ones that are probably I think they are the staff in our organization that have the least ability to control the environment that they are going out into, because all of the folks that they're serving are homebound. And so if they're going to serve them, they have to be in that space. So
Are those units stored here and charged here, or do they take them home?
they take them home. So the little fobs that they have, they keep them with them.
How expensive are they, and is there a continuing service charge or a?
Do you remember?
There it is. I've got it.
125 a month, or 125 to purchase the fob and $10 a month.
Yeah, that sounds about right.
Service.
Yeah.
There's not many places in the county where there's not cell service, right? I mean,
There's more than you would think.
There's some
On
pockets.
the roads. Not necessarily in their home, getting to their home.
Yeah.
Yeah, Michael.
Just a general comment. It was a very interesting presentation. I would for their support, I would describe it as an organized but aggressive approach to protecting safety of the staff. It's a very positive thing that's going on. Protect staff. There was some discussion about how formal this should be. Guidelines for safety or a policy demanding certain sorts of responsibilities on the part of the people taking care of themselves and being responsible for telling the organization when there are issues and what the organization should be doing. As a policy or at least a written procedure on both parts. Didn't explain that very well.
You know, we asked the staff, so should this be a policy that comes to the board for its approval, or is this an internal thing that John signs off on? And so we tasked John with coming up with, telling us which of those things it should be.
The other piece is that these are all personal vehicles of people, right?
Yeah.
Yeah, so I wasn't clear on like liability and such as if they get in a car wreck on their way, but it's their own personal vehicle, so it's work related. Is their insurance going to cover it, or is their insurance going to say, I don't know. Yeah,
During work hours, they're with procedures, they're covered during work hours while they're using their personally owned vehicle for work.
They're covered by us.
Yeah.
So we have 48 devices and 48 app subscriptions, so they can have it on their personal or work phone, as well as, or they could carry a device and or.
Interesting because we have employee safety devices and have done this for people at hotels, not only ours, but most hotels. And it's interesting how many people don't carry it. That's been the thing that we have noticed is they're supposed to do it, but they don't carry it. Now, they probably look at it as a risk reward kind of situation versus having this thing attached to them during the course of a 8-hour shift. But so it's interesting how they do it. If it, I guess the two questions I would have, one is if my car breaks down in the middle of nowhere. So that's one. To me, would be the safety if I'm walking into somebody's house and there's a domestic issue or something along those lines. That's where I would personally use it.
Yeah, and we have nurses and staff and aides that have been doing this for 30 years, and they know their people, and that's their prerogative. And then you've got staff who say, "Oh, I'm never walking into a house again without it," right? So.
What I was trying to say is we have a responsibility to protect the staff, but they have a responsibility to turn those devices on at all times. Kendra explained it as some of the individuals don't want to do this. They perceive it as government trying to protect their track their every movement. But staff has a responsibility to follow guidelines or policies, whichever that happens to be. One is stronger than the other. But
the term I would use is if we use as an organization, we use reasonable care. You'd probably like that one.
No, and we can, I mean, it's made the case for itself already with staff and, just helping with that flat tire issue. I had these similar devices when I was with the VA and on the North Carolina hurricane day. One of these devices was the only thing that saved one of our police officers' lives when he was dangling from his car, off flooded bridge. And so the cases speak for themselves as to why these are useful and why we care. I don't care where you are during the day. I care that you're safe. And so we'll continue to share that message with staff. But this isn't meant to be a tracking beacon. This is meant to be a safety tool.
Anything else? So we need a motion to accept the August 6th notes.
I move. Second.
All in favor?
All right.
Anyone opposed? Okay, Deanne.
Okay. Our committee, the Public Health Policy Development Committee met on August 6th also. With the legislative session coming up and the election coming up, That's kind of been our focus the last couple of meetings. And so we did several different things. We reviewed the 2025 Montana Legislative Public Health Policy agenda that we had put together before, and that John reorganized and made it so that it's more better for people to look at, because it highlights the very first item on each one of those areas so that people understand those are our priority areas in each one of those, under each section. So John is now taking on the role of, along with all of his other responsibilities, of shepherding the legislative priorities in the organization. And he has, I don't know whether he's met with all of these people, but he does have contact with all of these different groups locally and across the state that we have partnered with in the past. And so he will continue to do that and to keep the committee informed.
And I'm sorry, just to say that it's not just me, right? This is not advocacy and legislative work is not just one person's responsibility. I am absolutely taking the charge because that is my role and position. But we are expanding that to say, you know what, Melissa Henderson's the expert in public health. He can work with Confluence and public health legislative groups and public health advocacy and get the word out. Eric's got expertise in a certain area. Bob's got expertise in a certain area. Our entire leadership team is taking this on and meeting with other groups and people and building those relationships that need to be built. So
thank you for clarifying that. I appreciate that.
What, do you want a team?
Yeah.
Teams are good. Teams are good. So one of the pieces of news that kind of sad is that our lobbyist, Erin McGowan, who has worked with us for many, many sessions, will not be working with us this next one. So there will be a new lobbyist that will be hired, and we'll be working with that person for that company.
You know who that?
And that's through Confluence. That's through our state public health consortium, if you will. And so they hire them, just like the Montana Primary Care Association hires states to be our primary care lobbyist. Our professional organizations and our groups that we're a part of are hiring those lobbyists. We're not doing that directly.
Question: how much do you work with the county's lobbyists? I don't know if it is, but in the chamber's lobbyists, how much involvement do you have with either one of them or those? I don't even know who's the county lobbyist now.
We don't have our individual, we have Mako.
You go through Mako.
Right.
Yeah.
So we've been in, we've had contact with Mako, we've had contact with, especially now talking licensing fees and things that are potentially changing. We've been in contact. I've been in contact with the chamber. I'm going to have a meeting with John Brewer next week and talk about just that, those things. We had our meeting with Big Sky Economic Development, specifically on Medicaid expansion. So we've been pushing and getting out there and trying to share our messaging and get out. So we're going to have another couple meetings coming up, trying to do some meetings of the minds around getting all of the R's together and saying, hey, let's have a conversation. What are your concerns? What do we need to educate you on? What are the issues you're worried about? And have some joint meetings as well and keep on going.
Is there, and just thinking of it, because of our local legislators, I don't know, I know several of them that are in favor of healthcare and Medicaid expansion. But are you thinking anything after November, after the election, is to potentially even here in this boardroom is to have sort of a healthcare update for our local the people that are elected
for candidates,
and candidate, I'll sponsor the lunch or whatever, to at least try to make them aware of what we're looking at, because it's going to, by the time you get to Helena in January, it's difficult. So our objective seems to be, we have a short window from about November 10th to about December 24th.
Yes. So we had one for, and we do that with the hospital. So Adam from Intermountain, JJ from Buildings Clinic, and I, we had one for the candidates prior to the primary. And we'll have another one coming up in the fall for folks that have been elected. And so we do that in concert with the hospitals.
So
Okay, John's covered several other things that we talked about here. So one of the other things that we did in committee was we talked about how incredibly important it is for our board members, all of our board members, not just the members of that Public Health Policy Committee, to be aware of our issues and to be informed on those issues, so that if you are talking to a current candidate who's running, having the opportunity to express to them the things that are important to public health and to RiverStone, but definitely to public health. And we had a questionnaire that we all kind of filled out and talked about. And you'll find that in your packet. So what we realized after we got done with that is that those of us that were at the committee meeting were like, okay, I kind of understand, pretty much understand what it is that we are standing for and what we want done. But I don't want to get it wrong if I'm talking to a legislative person or a potential candidate. If I'm asking them what their opinion is or whether they will support us. I don't want to get it wrong. And
So we need printed
so we need
cards.
printed information. And so I'm going to turn it over to Melissa and Eric, and they can talk a little bit more about what they've done with that direction.
So in your packet, you received some what are sort of draft material. So after we did the sort of rating confidence scale with the subcommittees, we talked about the need for short talking points, kind of the 3 high-level messages to get across, as well as then some fact sheets that could help educate board members, but more importantly, be something that you could actually leave with the candidate to think more about. And so we're going to be sharing that with you over a series of meetings. Today, we only have the Medicaid expansion information, but that is a heavy lift. And so we thought, let's just let it be the showstopper today and we'll fill you in on the rest. But in your packet, you'll see what's projected on the board there. We have kind of 9 topics that we flagged as being the headliners of this legislative session. This is either coming from our partners, as John mentioned, like the Confluence Public Health Association, which is the umbrella for public health and environmental health professionals across the state, which I'm a board member of, or Montana Primary Care, Montana Hospital Association. For things that we know in the field, our local electeds are asking us about, tell me more about Kava Kratom. What is this? Should I be worried? And so that's really where we led with the 9 topics that you'll see here. We think that these are the ones that you're probably going to be asked about, or there will be opportunities. And then what we'll do is we'll give you 3 talking points and then a handy resource that's either created by another entity or that we've created in-house to help explain the issue. And today's is Medicaid expansion, like you mentioned. And so Eric and John are the experts in this topic area. I oversee a lot of our non-clinical programs. So while I'm familiar, this isn't my wheelhouse.
Yeah, and I think this is actually a Montana Healthcare Foundation flyer. It's kind of a twofer because one focuses on the behavioral health aspects of Medicaid expansion and one focuses more on the primary care medical aspects of Medicaid expansion. And so, you can see on the quick bullets, 300,000 Montanans are covered by Medicaid. We're one of the 40 states that has elected to expand Medicaid. However, that was not a permanent expansion. It was an expansion with a sunset that is being revisited in this legislative session. And you can see some of the other kind of key highlights of some of the data on the flyers here. So this is kind of the gist of what we'd like to give to you guys, a few of these every month. And just to be clear, we're not, as a government agency, telling legislators how they should vote, but we can absolutely educate them on the impacts of their votes. And so that's the type of information that we're going to be providing to you all. So these flyers have a little bit about impact on health outcomes, impact on economic outcomes. So a little bit of everything in here. I think one thing that stood out to me on this behavioral health one, if you kind of scroll down to the bottom of that second page on the behavioral health one, there's a lot of emphasis on shoring up our behavioral health system in this state right now. And the underpinning of that is Medicaid. If we don't have Medicaid, a lot of the other stuff that $300 million is kind of as seed funding for will just disintegrate into dust because there will be no providers there to serve the people. And so I think, kind of on the Medicaid front, one key takeaway is that if we want to continue our gains in enhancing and getting our behavioral health system to the point where it's actually meaningfully meeting the needs of our state residents, keeping Medicaid expansion is a key aspect of that. You can't have one without the other because that $300 million will go in a heartbeat. So if you go down further into the medical stuff, you can see improving healthcare access and outcomes, 11% decrease in inappropriate emergency room use, 30% decrease in dental conditions, and other key health indicator impacts of getting people insured, which we all know, but others don't.
Just an FYI, the QR code at the bottom doesn't work.
We'll have to tell them it's a healthcare
Build a foundation.
The other thing, can they?
I don't know. This one, yeah,
Oh yeah, their link doesn't work either. We'll let them know. Foundation.
Because of Jim Forte's love hate, I guess, on some of his things, can they draft take some of the things that he has said or he talks about or that I don't know how I'd say against, but and spin it in here? Because this is good to the general public, but also there's a portion of it that's got to be addressed to him in particular, in my opinion, and whether or not that's done in this, and maybe it could be as sort of a subliminal message of coming back. I mean, like when he says, okay, I don't want people taking advantage of the system. Okay, so that's been one of his big hits. So how do you craft this so that we're talking to that instead of this is good, this is what it does, it's how, but that's not talking to the guy that's going to either veto or pass something. And so to me, that's where some of these things at times, they're good education pieces, don't get me wrong. But I also think the comment I have going back is that, hey, he's shown his cards and as far as I'm concerned already.
Yep.
So what do we do and how's that addressed here? And going through it, I didn't feel comfortable with the address. If I were to go to him and talk to him and he would go, yeah, but I've got this, this and this.
Yep.
As against it.
So crafting that message is this is the presentation. I'll send this out to the board too, that we did for Big Sky Economic Development. Was crafting it on the HELP Act. It is an economically driven bill, right? And so going back to its roots and talking about the economics of Medicaid expansion, what is going to be, right? So we keep hearing, well, it's in HB2, it's in this bill, right? It's in the appropriations bill. They're going to have to legislate it and take it out if they don't want it. And so what we're doing to educate legislators is say, here's the funding, here's how it's presented in budget. Here are the work requirements that are already existing in the HELP Act, right? And that we already have in place in this state.
Yeah.
There's confusion about, people want to legislate and put those in this time around. And we're educating our legislators and saying, no, they're in the bill. Like these are the work requirements that we have. The fact that most Montanans, the majority of Montanans who are on Medicaid, are on Medicaid for less than 22 months, not forever, right? If you're on it forever, it's because you have a disability and you can't work, or there's another healthcare issue underlying that is making you be on this coverage, right? As it was intended. So what we're seeing as a lack of people gaming the system and working to those talking points, and the numbers are showing that folks aren't on it forever. They're on it for 22 months or less. It's having this economic input. It's having $6 million investment in medical education in this county itself. If we want to continue to have a teaching health center and continue to ensure physicians stay in Montana, we need Medicaid as it exists to help pay for those residency. And the other thing that we need to all do and stop doing, we need to stop saying expansion, and we need to say continued Medicaid coverage. Because the other misnomer that is out there is that we're going to expand expansion, and we're going to use even more taxpayer funds to take care of even more people that folks don't think should get this coverage. We're not expanding a program, it's already expanded. And so we need to start saying we're going to continue Medicaid coverage for those who need it. Maintain Medicaid coverage, right?
Yeah, I think some of those things would be beneficial.
In the talking points.
Yes.
They will go in there. And also people will say, well, we can't afford it. I mean, the overall expense, I think it's important that it doesn't cost us that much.
The education is money. Well, it's not only saving saving $28 million in the state budget every single year.
Yeah.
And it's saving our hospitals over $150 million in uncompensated care. 90% of all of the expenditure is being given to the state of Montana by the federal government. And so it's a 10% buy-in from the state.
And most of the conversations we have with the legislators are probably going to be about Medicaid. I mean, we've got to on the state side too.
Right.
So I think that with that particular topic, it doesn't hurt to have a whole page though.
For sure.
I think a lot of things, 3 years is enough, but
for sure,
that one, we really need to be armed.
Yeah. And it's, for you, Steve, more than 30% of folks on Medicaid here in Yellowstone County are in the hotel and lodging industry. Daycare and child workers, food service workers. A quarter of the folks here in Yellowstone County, personal care aides, restaurant wait staff, retail, industrial labor. The fact that there's this misnomer that people on Medicaid don't work, the vast majority are working or are in school or are a caretaker. And so we just have to continue to educate and share the facts.
That number, if you show that supporting those workbooks, one of the things you should put there is that I can't give you the number, but I would venture to say 90% of the hotels in Billings are under 50 employees. 95% probably. And so when you look at the number of restaurants and you look at the number of people, I would look to have that as part of it, so that they go, oh, okay, well, they're 30%. Well, I'm part of that 30%, but I'm over 50 employees, full-time employees. And so none of my people, unless they do it because I provide healthcare coverage. So, I mean, I think there's a way of spinning it that it's these are for the people that are utilizing.
So I'm like, it's over 50 employees, and I don't know how many different patients I've had who have had Medicaid who are Walmart employees.
Well, that is-
So
that is-
we,
that is
you know,
true.
the federal government is subsidizing.
Well, and I think that's to a certain degree where Gene 14 comes into play. And he says, well, those people are gaming the system, and those are the people that really don't need it, that should be on it. Walmart should be doing. So I think that's, you know, and that spins, you know, when you hear that with the legislature, especially the Republican legislature, they're going, well, yeah, that's right. And that's it. So our message has got to be a little more refined.
That's the major retailer gap.
Yeah.
That is the major retailer gap. Is let me pay you enough of a wage that you get money, but not enough that we need to provide you with healthcare.
But I consider you part-time.
Right.
So you're not eligible
Right.
for health insurance.
Right.
You know, we used to be the #1 state in the country for uninsured. Gee, I don't want to be #1 in that category. And we haven't been since this whole,
Absolutely.
since Medicaid was expanded.
Yeah.
So our plan is to, we'll go back and we'll beat up the vote on this one. This discussion, we'll bring it back. But then kind of moving forward over the next couple of months, bring you guys, 3 or 4 each month that are covering the topics that were listed on that document. So firearm storage, suicide prevention, information on designer drugs, adjusted licensing establishment fees, IMSS requirements, including in childcare settings, support for community health centers, some support for foundational public health services and infrastructure, and information on your guys' role in local decision-making and protecting that local decision-making.
Thank you.
If there are other topics that come to mind that you need to know about, I think that this would be a great space to let us know. This is what the Public Health Policy Committee and staff agreed were the priorities, but I guess something.
That's excellent. Can I do a small, are you guys done with this piece? I have a lot of change and.
Well, I just wanted to bring up one other thing. I think one of the things that when we talk about the role of the Board of Health in local decision-making, I think that there's things that we can bring up that we really have not really delved into, because we can't make those decisions. We can't create a new policy, or I'm not saying the right words, but because of what the legislature did 2 years ago. So, we need to have the right words to say. Not me just kind of fumbling for what those words are. But I really feel, as the chair of this committee, that we have been kind of stagnant because we don't know what we can do. So.
Well, I think you can put anything together and then John takes it to that other committee. So I don't think I should hold you back. It might get shot down, but you can always push that envelope and say, hey, we want to put this forward, let John take it to this bigger committee. So I don't think I'd use that as an excuse not to do anything.
Okay, well, I wasn't.
Just my thought on that is, don't let it stop you.
Okay.
Push the envelope, but if they may say no, but let them say no.
Well, no, also, just to add, it's a little hard because, you know, public health policy isn't something that you bring to a meeting and vote on it and then implement that month, all in 1 month, right? Like, public health policy is something that can take years to shift. And so we do have some things on the horizon that we're looking at, get a little bit of some staffing changes, particularly in environmental health, that we'll be bringing to you all. But again, it's like the tobacco in the parks kind of, or thing, right? Like, we put together a work plan that's a year of just education in service to getting to the point where we might have a public health policy that expands the, you know, clean air rules to parks eventually. So it's kind of one of those things that's a little slow moving and takes a lot of education and stakeholder hand holding along the way, I think.
So I don't know, you had a question?
Yeah, well, I had a state comment. You know, how at the beginning of our materials, when we come to our meetings, we've got the 4 pillars, we've got our justice, equity, diversion, and statements of commitment, and we also have our customer values proposition. What I think be helpful to me would be as a part of the public policy agenda, to have a sort of a reminder every month, something like that, that here are our priorities as an organization long term. And here are some of the bullet points that would also help us. So this keeps coming back at us, because I mean, I could look at this and then, you know, walk out of the room, and 3 minutes later, I'll scratch my head and wonder, what was that? If I'm constantly reminded, I would find that.
So, and before we get to your thing, we need a motion to accept the August 6th notes. All in favor?
Aye.
Okay. Did you have a comment, Michael?
I'll hold on.
Ann?
Yeah, the comment over there.
Oh, sorry, Don.
So something to think about when you're looking at, you know, the legislature and everything else. I think the behavioral health side of it and our jail locally might be something that you want to look at as far as information on how that can make a difference. We have a lot of people in our jail that have mental health issues that, you know, we don't know what to do with them. So I would suggest that maybe that might be a real strong speaking point with us having to build a new jail and everything. So tie those two together. That was it.
So just a slight change, but it's along the public, obviously public health policy piece is there, and maybe this is what you guys are talking about, is in terms of like the health inspectors and such, are we having a shift of policy? Like, are we going to or considering a restaurant grading system or something? If so, are all the stakeholders involved in that decision, including like the inspect people who go out and inspect and what their opinion is and such like that? I know it's been implemented in other places, but like personally going to a restaurant that has a C grade or something is potentially problematic. And if that occurs because they had one bad afternoon and someone happened to show up and inspect, maybe it's okay. But how do the restaurants get out of that and change it? Or are they stuck with that grade till the next time someone randomly, and things like that?
C is for chocolate.
C is for chocolate, yeah, maybe. We saw you like an A on your door.
We've started having these conversations just preliminarily at EHS staff meetings. I oversee the environmental health team currently, and so we've started having preliminary discussions. We had applied for a CDC associate to run the project. Unfortunately, the match was about 16% because of the CDC's reduced budget, they weren't able to provide as many associates as sites. And so right now we're hiring a tech position, and that person would actually be the lead on this project. But we have started talking about what would, obviously staff are going to be the key project team, and we have the luxury of having sanitarians who have worked in systems that had grading, either kind of the positive, the negative, how do you kind of get out of your grade or improve your grade? But then we're also looking to engage the restaurant operators themselves in that. And so we have some DoorDash drivers that are very passionate about what they see. And so we're also hoping to engage just the broader audience and public.
Yeah, I think the state used to do a system where you could, rather than like something stick, like,
yeah,
there was a carrot where you could go above and beyond to get star ratings or something.
And we've talked about, is that the model? We want to be able to present both and see what's going to create that social norming, because grading is more about social norming and that, oh, see, I don't know about that, than it is.
Because it's already online, like inspection reports are out there. You can look them up.
Yeah, you can't necessarily look up complaints though, which is tricky, right? So that if a restaurant passes its inspections every time, it's going to look good. But if John complains about a restaurant every single month, that's not necessarily going on the website.
I'm just glad that all the stakeholders are going to pull into it.
Just check my Google reviews.
Yeah, I mean, that's a great example of how public health policy can take years, right? Because if we just rammed it through, we'd have a lot of upset restaurant owners, right?
They don't want to necessarily put people in business for.
No, and the ones that have been successful have had a lot of stakeholder engagement, involvement in the development of the, what is the grading system?
Right. Is it a platinum piece?
Are we going to do an ABC? Are we going to do a sad face to a happy face? Are we, are we? So different areas have different ways of doing the quote unquote scoring. Another big element of it is assurance to the community that we have enough standardization that when an A is an A, it's an A, right? And and most places that have done this successfully have put, usually from what I've seen in some of the case studies and literature, it's a minimum of a 3-year process to get from we want to do this to stakeholder engagement to starting out with it as voluntary participation to now it's a requirement for you to post that you've passed your inspection on your front door. So it's going to be a long project.
And I would just add to that the team's goal for this fiscal year is to come up with a proposal to bring to this group. So our goal is that by next summer, we would be coming to this group with a recommendation of what we heard, what we saw, what we think makes sense to get your feedback, and then we launch into a pilot phase.
So I've got a question. What's the problem you're trying to cure? I'm trying to ask.
Are the restaurant owners asking for this?
Well, I mean, it's not in New York, California, those areas, but I'm just curious, what's the problem? I mean, if you told me that, Steve, in Billings, 50% of our Yellowstone County, 50% of our restaurants are quote unquote failing, and what is defined as failing, then it's there. There's a problem. And so I think from a restaurateur person, you bring this and you say, okay, my first question is going to be to you. What problem are you trying to solve?
John, if it works.
Policy committee and the board, going back 15 plus years, started discussing this, and it never had traction because there was little public interest. There are priorities that need. I look at some of these lists, and this one doesn't strike me as a terribly high priority, and that's after having dealt with it at the policy committee level. And I think, Steve, I think your comment was correct. There wasn't very much interest on the part of the industry, the population. But there's a long list of important things there, and it takes time we need to set priorities and do what needs to be done that's going to solve some significant problems. Sorry, childhood immunizations and daycares, some serious places that need some aggressive attention. I don't think this is one. And that's coming from a person who likes to cook and likes cleanliness as well.
But if they told you 50–60% of the restaurants in Yellowstone County, quote unquote, are failing because of cleanliness, then it is a higher priority. But
if it is,
yeah, that's what I'm saying. What's the problem we're trying to do?
The news is that we're in the middle of a risk factor study. So because we are standardized by the FDA as a health department, every 5 years we complete a risk factor study. And the exciting part is this will be our third study. So we can look at trending to see what's changing. And that'll,
if anything needs to be done at all.
right. And that'll help. And we use those to basically develop our strategic plan for the department based on those. And so kind of just really quickly answer your question. One of the complaints we hear from customers and really from food operators alike is, why is this tolerated at that restaurant? But I feel like I'm doing everything right. And a pass is a pass, a fail is a fail. Like, where is the kind of level of quality in that? And what our sanitarians struggle with is, if you're doing the high risk things well, you're going to pass, right? But what about the other things that are really sketchy that go beyond those first 5? And so trying to kind of figure out how do we elevate the standard of
So something for you to think about.
Yeah.
In doing it is so those high touch areas are those that are very vulnerable to the temperature of food in particular. Okay.
Exactly.
So you could have those as okay, pass fail, but then the second level of people. So do I have something stored on the floor, or is it on a rack, or is it above the floor? Is it lifted off the floor? So that could be a comply, non-comply.
Right.
And so what you could do is you could have, okay, hey, you get more than 10 non-complies or whatever. So you take those items that are very serious within the restaurant, and those really do become pass fail. That doesn't bother me at all. And then you have comply, non-comply, and similar to what they do now, because if my steam table is not, they'll come back in a week and go. And so that's how
there
legally
be some
I think.
non-negotiables, but I think this is more intended to deal with those in-betweens that can cause risk,
Sure.
but aren't.
So I wanted to expand this just a little bit more, but it's way off the serious side. And that is the DoorDash drivers that are complaining about the restaurants. I think they should have a grading system for the DoorDash drivers. Some of the pickup my food that I was going home by the time. They can eat that before it gets there. So that's a lot. Yeah. So
but we have an ecosystem, right? We have the whole ecosystem, and that's the thing we found with the last outbreak, right? Is one of our potential people was a DoorDasher. Yeah. And so what role did they play? It's this whole
what is their
This is really good. I know this wasn't part of the discussion, but this is really helpful, and I'll definitely take it back to.
You can tell we all like to eat.
Yeah. We never really, it's one of the few things, we hardly ever talk about that piece of RiverStone. Yeah, hardly ever discuss it. And I think it's actually important. I mean, how many restaurant people are there, right? Or were there?
Now we're gonna have a report from Carol on the foundation. Yes, okay.
Okay, this will just be quick. The foundation board met yesterday. We're still in a little bit of a reset mode with the change in leadership of our executive director. Really great engagement from all of the individuals who are on the board. We had John gave us a good presentation yesterday of some of the key priorities that we can start looking at for new fundraising opportunities. And then Eric and Joe, thank you. Yeah. We had about a half hour, 45-minute overview of the school health clinic programs, which is a high priority. And the foundation is giving a serious look at that project for fundraising campaign. So,
And we will have presentation here next.
Yeah, so it was very, we're headed in a good direction with the foundation and getting things in place so that when people want to give us money, we have opportunities for them to help us fund projects. And it's important to have, people give money to things that they are really passionate about. And we want to make sure that we've got places that that money can go if they're passionate about it. So all good things going on at the foundation. So, thank you. Does anybody have any questions?
Good to hear.
Yeah, it's real good.
And the program next meeting Tuesday.
Yeah, we will be, I think the request from the foundation board and from our board chair was that we have the school-based health center presentation modified for board education at the Board of Health so that you all are aware of what are we doing and what is the impact of expanding school-based services across the community. So I think we'll add it to the list, Aaron.
Yep. And when you think about school-based services, a lot of us think about school nurses that have been, this is very different. Right. This is, think about a school that actually has a little primary care clinic attached to it or within its walls. That's really what these school-based clinics are smaller primary care clinics that address medical and behavioral health services. So
is it the thought that subject might be the topic of I don't know if you call it a capital campaign or not, but it's a particular campaign to raise money?
It certainly could be, because to start to put a clinic in a new school, there's a cost to do that, because you've got to have some space, you've got to have equipment. So that there's the startup cost as well as the ongoing funding.
And so far, they found that once it started, it's self-sustaining.
It operates like a clinic in that if you have insurance, if you're a child or a student and your parents have you on their insurance, then your insurance gets billed for that visit, just like if you went to the children's clinic or something like that.
So Orchard School Clinic, it's paying for itself now?
Mm-hmm. And then there's one at is it
Medicine
Scale?
Medicine, both Orchard and Medicine Pro are
right. Yeah.
covering their costs, yes.
And seniors started.
Well, it depends. Medicine Crow, we have a grant that's within that Everywhere grant that really does help supplement that. But really, when we do all of the models and the projections that we've done for additional school-based health centers, they cover themselves fairly quickly, like within a year. I mean, looking at them, they're really self-sustaining. Really? Yeah, obviously depends a little bit what we see in payer mix within those different schools, but organizationally, it has been something.
And that covers the cost of our
staffing. Yeah, I mean, really, it's staffing. The space is donated within the schools, so that's the biggest piece. Is
where does most of the income come from? Is it from private insurance, self-pay?
Medicaid, very, very high proportion of Medicaid. We have the financial formula that makes Medicaid work for us as a community health center. They're all in scope community health center services when we're in the schools. And so the good thing about being in the schools is we're not really working through any redetermination issues or unwinding issues, because the pediatric population tends to remain stable and on Medicaid and has that ongoing need for Medicaid covering.
So does the school nurse?
No, it's
still there,
staffed by,
or do they
yes.
go away?
Yeah, no, the school nurses, they have a very different role.
Can it be combined though?
Yeah.
At some point,
School nurses typically in the school, maybe 2 or 3 half days a week.
Yeah.
Debbie, I would love to have your input here on SD2 school nursing. But it is very different in terms of what services they deliver, what services legally they can deliver, as inputted by the state. and how what the school counselors can do. So we'll do things that are different than and out of the scope of the school counselors that are employed by the school district and the school nurses as they're employed and as Debbie points out, licensed by the school district. So very different roles and very different opportunities for us to impact the health and well-being of the kids. We tend to focus more on the acute care needs with folks that have tummy troubles or are sick with the flu or something else and need a medical provider attention during a school day.
Yeah, like aren't school nurses primarily doing like tracheostomy care, G-tube feedings, medications for kids who are on meds and stuff versus someone who has an acute issue?
Yeah, Debbie's probably typing.
Debbie's typing in. Yeah.
Yes, so in a school nurse, they're operating off of an order from a provider, basically. So a provider sends to the school a care plan, and the nurses are executing that care plan. And mostly, like you said, it's med admin, some care for kids with disabilities or special health care needs that need to get handled during the day. And in the school-based health centers, they're establishing care with us as if they're our patients. So we are the prescribers.
There. Very different role.
Yeah. So it'll continue to be a partnership as it is, and some of the spaces that are available out there for expanding into other schools, we'll need to share space with school nurses potentially. We'll need to expand into a mobile unit potentially, and there'll be plenty of other opportunities. But it is going to continue to be a partnership with SD2. With the counselors, with Debbie's team, with the school nurses, and others that are out there to just provide additional points of access to care. And the number one thing that we're providing is opportunity to access behavioral health services and counseling that is not currently available in schools that we're going into.
So we're almost out of time. We have two quick things to do. In the executive session, we approved the evaluation we had of John, but we need to do that publicly.
I move we approve it.
Second.
All in favor?
Aye.
Any objection? And then the second one is we have to approve the updated truck wreck protocol.
I move we approve this.
All in favor?
My dad was a truck driver, so I know.
You know something. And we are adjourned.
Thank you all.